health outcomes for Black women. This is not just a healthcare issue, it's a social justice issue that impacts families, communities, and future generations. So today's discussion will delve into the barriers to care for Black mothers and what they may encounter in the rural parts of wherever state you may be coming from. But most importantly, we want to talk about solutions, how we can improve healthcare access, advocate for policy changes, and support community-driven initiatives. And so we have an esteemed panel today that is sitting before you, which brings a wealth of expertise from different corners of healthcare, policy, and community advocacy. Together, we'll see what we can do to work this out, but I'm excited to hear some of these voices and get right into the work. So let's turn it over to our panelists.
Doug Cole, thank you so much. We'll do just that. And the panel, this is an expert group, and they're also mostly legislators, not exclusively. We have several practitioners with us as well. But I'm going to give our first question to Representative Ann McDaniel, and then Representative Park Cannon. So Annie's from South Carolina, Park from Georgia. And the first question is, what are the primary barriers to accessing maternal health services for Black women in rural areas? And please introduce yourselves as you answer this first question.
Thank you very much for that question. I am Annie McDaniel from South Carolina. I serve House District 41, which includes 3 counties, Westboro, Fairfield County, South Carolina, part of Richmond County, and a portion of Chester. Chester and Fairfield are very, very rural counties within my district. Thank you. The portion of Richland County is not as rural, and it's kind of ironic that I'll be chairing our Legislative Black Caucus in January. And one of the things that we are putting in place is a rural caucus. So we will be looking at the maternal health and access within those rural counties. We had a number of our hospitals that have closed in our rural communities. So lack of health care is a serious issue in South Carolina. But as it relates to the question and some of the barriers, definitely transportation for a lot of our individuals. We are trying to do more with mobile units going to those rural communities. We are trying to do more with telemedicine. But what we find with telemedicine is that until access to the internet and broadband is increased and strengthened, then that barrier is still there, and it's still just not accessible by many. And what we're also finding in South Carolina, we are a tourist state, so we have a lot of individuals, seniors. So them getting access is more of a problem, again, with the driving, with the transportation. So I'm here and just enjoy listening to what some of the others are encountering. But those are a lot of the barriers in having healthcare providers within those areas. And just real quickly, if I may, just one thing I would like for us to consider as it relates to helping with the rural healthcare is just making sure that we are able to provide transportation as a state to go into those areas and make sure that the funding is there for the counties to send persons in with those mobile units, and also to provide transportation where they are able to take advantage of that. So again, thank you, and thank you for having me.
Representative McDaniel, thank you very much. We do not have a Representative Cannon with us, but I was going to add Representative Vivian Flowers. We have Vivian. Oh, no, Vivian, I've gone 0 for 2 there. Let's go to Marilyn, right there. Thank you, Marilyn.
Thank you, and I'm very honored to be here today. I represent Alabama House District 10, and full disclosure, I came in March 26th of this year on a special. I ran on reproductive freedom, and I shared my own abortion story. So I am hoping to champion maternal health care. And at the end of the session, I introduced my first bill. It was the last day it could have made it through if all the planets aligned, and they did not. But it was a bill to provide presumptive eligibility to pregnant women to Medicaid. And I had good bipartisan support. I felt very hopeful. I'm looking forward to reintroducing that. But as I've delved into this and have been talking with key stakeholders and others and trying to sort out, this whole issue is like a knot, and I feel like I'm trying to unravel it. And there are so many barriers. Insurance is just one of them. There's all the logistics. There's the transportation. We are losing our hospitals and OBGYN services at a very rapid rate. We're one of a handful of states now that have not expanded Medicaid. We're seeing a lot of physicians flee the state at this point. I don't think we've looked at the unintended economic consequences. The reimbursement rate is another big barrier, and just the economies of scale in trying to run a hospital that provides labor and delivery services. And then because of my background as a licensed professional counselor, I'm always deeply concerned about the mental health aspects of these situations. And pregnancy is it's a risky thing on a good day, and it's a frightening thing. And we see not just postpartum issues, but mental health issues during pregnancies. And not just the women, the men too. I think someone brought that up. So I think there's a myriad of problems, and I'm trying to untangle that knot and see what we can do in Alabama to introduce something that offers a much more comprehensive package to deal with maternal health outcomes, and especially with our Black women. It's unacceptable where we are at the moment. Thank you.
Representative Lance, thank you, and thanks for jumping into the fire as being so recently elected. Let's go to our second question, and we'll get a couple of different panelists on this, and again, ask you to introduce yourselves as we get to that question. The second question is, how can community-based programs effectively support Black maternal health in rural areas? And I'll start with Representative Mary Frances Clardy from Minnesota.
Good day. Not sure if it's morning or afternoon. I just finished my first term. My name's Mary Frances Clardy. I'm a representative from the state of Minnesota. In Minnesota, a couple of things that we've done is we have a birth justice collaboration, which provides support to culturally appropriate care for Black and Indigenous people. And so that organization works with healthcare systems to make sure that they're sensitive and aware of what's culturally appropriate. So that's kind of a big thing that we did. That just went into place in 2023. The other thing is we have a Black maternal caucus, and it's kind of a big deal in Minnesota because there were probably 5 Black women that are, in the House, but we did it, and we have some really strong bills that are looking at like fibroids. We're looking at, mortality. We're looking at pre and post mental health. We have all these things outlined. So those are 2 significant things that we're doing in Minnesota.
Thank you so much. I need a quick housekeeping thing for the members of the panel. I've already spoken. If you can you can mute your mic, just press that button. That would be great. So you're the red button. Yes, you're not red anymore. Thank you very much. Let's have Senator Tracy Davis from Florida weigh in on this as well.
Thank you. Good afternoon. Well, I think it's still good morning. So I am Tracy Davis. I'm a senator from Florida representing District 5. And this is an awesome question. I think a lot of this has already been discussed if we all left the large room upstairs. And I look to my right to add to the conversation that my colleague was having. Anytime a woman has a conversation and she shares her experience with an abortion, I always feel the need to make sure you know that you're not alone. I share my same experience because I don't think any of us, women, Black, brown, any of us should feel ashamed about any of those experiences. So I wanted you to know that I have that same experience, and I have had an abortion of my own. So jumping back to the question, like I said, if any of us have spent time in that room that we're in, a lot of this has already been said. So when you're talking about community-based programs and what are some things I guess in Florida, we've tried to effectively do is we have doula certifications. You heard a lot about that. We have to have people that look like our mothers, that are Black mothers, inside of these rooms. It's a physician shortage. It's a doula shortage. It's a midwife shortage. And we have to have more of these people inside the rooms taking care of our mothers. So there's someone that's providing a supportive base for these mothers and these families. And so that's a couple of things we've done in Florida. But that's also expanding access. We've heard that too in the room above. And it's about the community organizations, and our community organizations can help us remedy some of these barriers that we have. It's also, you've already heard, the mobile health clinics. That's something that is terribly needed to rid us of some of these barriers that we're having, in our community-based organizations can definitely assist in that as well. But at the end of the day, we know all of this depends on what? Dollars and cents, right? And we can't have any of this conversation if we're not, as legislators, serious about putting dollars and cents in the community to ensure that these community-based organizations are able to help us with remedying some of these barriers that we have. Thank you for the opportunity.
Senator Davis, thank you. And again, I mean to keep emphasizing this to all the panelists. Thank you for being here. Folks have traveled from far and near to join this, to be with us here in Virginia. And we're already benefiting from your presence and from your experience and what you're sharing with us. So thank you so much for that. The next question is more specifically focused on the education component of this. And that speaks to a lot of the workforce issues in terms of getting more people into these professions at all levels, and we need folks at all levels. So I'm going to ask John Stroffolino from Germanna Community College, one of our Virginia community colleges, to take this question first, and that is, what role can community colleges and local institutions play in delivering care to rural communities?
Thank you. John Stroffolino. I am the Associate Dean of Health Technologies at Germanna Community College. So that's about located halfway between here and DC. So we serve a large service area. We have 7 counties and also the city of Fredericksburg. And last October, we were approached by the Virginia Department of Health and also the Virginia Department of Medical Assistive Services. And we were really looking at the role of doulas in our community. We were looking at some of the disparities. And Valerie Hobson-Bell is not here today, but I know we have Natasha Turner is here, and she works for DEMOS. And we had a really collaborative discussion over the course of October through into the summer about starting a doula program at our college, at Germanna. And we were looking at not just the challenges in the state, we were also looking specifically at Planning District 16, and then also in terms of the city of Fredericksburg, and how those maternal outcomes, as you hone down, they got worse and worse. So we really looked at the role that doulas can have, and Virginia is one of 4 states that Medicaid will reimburse for doula services. So we worked with some of our faculty. We worked with our Associate Vice President of Health Sciences, Dr. Nanette Graham, and we developed a program. We worked with the Virginia Certification Board, looking at their 60 hours of credit, 60 hours of training. We developed a 6-week program to deliver those, and it was taught by 2 doulas. We had it in Zoom format, some in-person format, and some asynchronous format. We also facilitated the students to have observations in our local healthcare facilities, in the labor and delivery, so they could witness and see live births and then guide them toward that certification process so that they could be Medicaid certified doulas. So it was really something that we did, a collaborative effort to really help to address some of the needs in our communities. And our service area is very wide. It's not just the more urban area of Fredericksburg, if you want to think of Fredericksburg as urban, but we have some very rural areas as well in terms of the communities we serve. And this was something that was a need, and the Virginia Department of Health, our local planning district, was able to actually secure funding for our first cohort. That just finished up in September, and we're looking at debriefing, making some micro adjustments for our second and third cohort that'll start in 2025.
That's excellent and great to hear Germaine is leading the way on that doula program. That's really exciting. Let's also have for this question. I'm going to ask. We actually have a representative from the Virginia University of Lynchburg, Dr. Brown, and have you weigh in on this one.
Sorry. I'm Laura Tucker. I'm from the Virginia University of Lynchburg. We're a historically black university located in central to southwest Virginia. Some of the things we've done, I hold a doctorate in healthcare administration from Virginia University of Lynchburg. We have implemented that program to help leaders in healthcare administration, administer their programs. That program is key to being a change agent for the types of changes we're talking about in rural delivery as well as all healthcare delivery. One of the things we're doing at our institution is we're very community focused. Our president believes in taking care of people, meeting them where they are, and that culture has expanded across our institution. We've partnered with some healthcare providers in the area, as well as a mobile surgical unit to explore ways to deliver healthcare to rural Virginia, focused on maternal healthcare. Now, there's many facets to it. As educators, we're both protectors and disseminators of knowledge, and hopefully some of that may be a change agent. So in protecting the knowledge and disseminating the knowledge through the research, we have to understand what those communities really need. You can ask them, but you've got to be careful how you ask them, because you really want to know. You don't want to ask leading questions. You want to hear from them. You really want to know what they need. And that's what we're focused on, is learning what they need, how we can solve the transportation issues, how we can provide the child care so that they can take advantage of the health care when it's in the area. What types of services do you need? What are the barriers to you? All of that is being built into our model of the community service delivery, making sure that the healthcare providers are culturally sensitive to the people in the area and are able to meet them where they are and understand their needs. So those are some of the things we're doing, providing a holistic model, a patient-central model that provides not only the actual unit and the facility for the care, but a whole community of services and support that's focused on what they need. Thank you, Dr. Willett.
That's great. And I think you've got someone who's working with you sitting next to you, so I'm going to ask Rick Cochran from Advanced Mobile Solutions to weigh in on this as well. Rick, please introduce yourself too.
Yes, Rick Cochran, president of Advanced Mobile Solutions, and my background was starting the very first in 1996. We had the first mobile surgical unit in the United States that was utilized for hospitals during renovations, so they can keep an uptime capability. And it's an integration of technology, and now we're talking about an integration of systems within the community when we talk about the mental health requirements, when we talk about, as Dr. Tucker just mentioned, how do you get the patients to come? And we said, okay, let's look at our model. Let's have drivers. Let's have mobile, capabilities to bring people to our facilities. Let's have technology in terms of our computers and our and phones that we can utilize to stay communicating with the patients. And then with some of the technology that's changed dramatically, in this case with maternal health challenges, and it was mentioned earlier about the fibroid concerns. And there's technologies now that eliminate the need for surgery, where you can use a high-intensity focused ultrasound to help a patient solve some of those healthcare initiatives. I appreciate very much the leadership of Delegate Willett and Dr. Cole and thinking through how the state of Virginia might change the paradigm. And I think right here, the Virginia University of Lynchburg is taking that holistic approach. They are looking at reaching people that need care in these underserved areas. Many years ago, we did the first mobile breast care comprehensive. So you did everything from basic clinical care to digital mammography to ultrasound and colposcopies. And the concept was to do things in a matter of hours and briefly short circuit that cycle where patients maybe wouldn't get the care because they don't tend to go. 50% of patients in many of these communities, including in the maternal side, is they don't show up for the appointments, and we have to solve those problems. And I think we have an excellent solution. I think we have an integrated solution that can do just that. Thank you so much.
Rick, thank you for sharing that. That it's impressive technology if you haven't seen it, to be able to meet people where they are. It's really impressive. Our next question is actually really related to the last question. We were talking about transportation, getting into the transportation theme in terms of meeting people where they are. And I will just say, Delegate Cole and I have heard not once, not twice, but probably a dozen times at this point that transportation is probably one of the biggest issues facing us in the rural areas, and it absolutely is impacting patients of color, and particularly women, because it's not just one appointment that you're trying to get to. Let's say if you're as a pregnant mother, it's a regular recurring thing that you need to be doing, and the challenges they're facing when you're talking about folks in Southwest Virginia, where you say, oh, that's only 20 miles away. Well, 20 miles is an hour and a half if you have a car. If you have transportation, someone can get you there. So these are huge issues. I was going to ask, I'm checking my list here to make sure, we've got Ann Bonte, who's the Director of Women's Health with the Guinan Diaspora Nurses Alliance. If she could weigh in on transportation, we'll get a couple other folks as well.
Hello, everyone. I'm Ann Bonte. I'm a labor and delivery nurse, and I'm also Director of Women's Health for a nonprofit called Ghanaian Diaspora Nursing Alliance. Just a quick thing about our organization. What we are trying to do is bridge the nursing educational gap from the diaspora to Ghana to hopefully increase and help the educational standard and improve the health outcomes in Ghana. In terms of transportation, the implications of the lack of transportation, there's a lot of issues that come with that. One of the big things is inconsistent care. Before even women getting pregnant and them living in those rural communities, a lot of them have inconsistent care. Reason why a lot of them, they don't find out that they have certain issues, especially cardiac issues, until they get pregnant. And so one of the things that us as GDNA that we are trying to implement in Ghana is to have this midwife-assisted device where it's an AI-powered ultrasound. We're training the midwives to be able to go out into the communities, the rural communities, to be able to check for perinatal cardiomyopathy. And so that's something that can be implemented here in the U.S. to even train doulas to go out in the community and, use these ultrasound-assisted devices for these patients. So that's my answer. Thank you.
If you haven't seen I'll call it the handheld version of the ultrasound, it's very impressive. The portability of that is just remarkable. Just speaking from personal experience, going with my wife to ultrasounds for our 3 kids over a course of years, that was absolutely every single time a trip to the doctor's office and time consuming to do that. And you think about the mothers who don't necessarily have that access. This is really a game changer out there. We've got Senator Arthur Ellis with us from Maryland. And Senator, would you weigh in on this as well in terms of perspective on transportation issues?
Yeah, thank you, Mr. Chairman. Thank you so much for being here. It's an honor to be here. And folks always ask, what's a guy senator have as his main priority, black maternal health? Well, I always tell folks that I represent everyone in my district, and my district has become majority African American over the last few years. And I have to really make sure that I take care of everyone in my district. And the first thing I put in as a senator, when my first bill was the doula bill. And Maryland became one of the first states to make it a statewide program, so that's being paid for, implemented now. And we still have work to do, reimbursement rates and all that. And we will continue to fight hard in the maternal health area. And we would just want to make sure that our citizens, our constituents can get to medical appointment. And I represent a rural area in southern Maryland, and transportation is a big issue there. We don't have the buses and we don't have the trains. And so one of my big initiatives is to get the buses and the trains into our district. But in the meantime, we have non-emergency medical transportation issues where we have these private companies that can help in non-emergency medical transportation. So a couple of years ago, I put in a bill, a transportation revamp bill, which passed, became law, which allowed the state to pay for non-emergency medical transportation for all our citizens. We took off the limits, and we have to make sure that the administration budget money every year to take care of all the needs. So there are things we have to do, there are things we are doing to solve these problems long-term, and there are short-term things which we have addressed to take care of the gap. So thank you for listening.
Senator Ellis, thank you so much for being here and sharing that with us. And I hope as a male weighing in as well on these issues, I think it takes everyone. We need everyone weighing in. So thank you for sharing your opinions on this. Question number 5, and I will tell you, just as a preview, we've gotten some excellent questions from the audience as well. So we're going to do one more question for the panelists from me and Josh Cole, and then we will pivot to the audience questions. But for question number 5, this is a question: in what ways can local health policies be improved to better serve black mothers and rural communities? I'm going to ask Dr. George Sade from the Eastern Virginia Medical School, Old Dominion University, to kick that one off.
Hi, thank you for including me, and thank you for putting this important legislative summit. I am the chair of obstetrics and gynecology at Eastern Virginia Medical School at Old Dominion University, and the associate dean for women's health. Prior to joining EVMS about 2 years ago, I worked in a large state with a large rural population. I was the chief of obstetrics there. And our health system included several clinics in rural areas, sometimes often 4 to 5 hours away from our tertiary care hospital. So I'm going to lean on some of that experience in answering this question. And I think we need to redesign our system, how we provide health care for pregnant women, particularly black pregnant women, in developing community-based clinics that are connected to a centralized system, health system, or a tertiary care system. The two important things, many different factors affect the success of these clinics, but to me, the two most important things were IT, how we connected these clinics to the hub. We had electronic health records that were common to all these clinics and the hub, where we could do consults through electronic health records, asynchronous consults, not at the same time. But we also had telehealth, ability to do telehealth for real-time communication. The other important aspect to me was what we called the domicile, which was a converted motel, 25 rooms, where women who had to be close to the hospital or had to have frequent appointments, sometimes twice a week, sometimes 3 times a week, could stay with support from the health system to monitor them. So to me, that was important. The other aspect was mentioned earlier this morning, is not to think only of the pregnancy, but to think of before the pregnancy and after the pregnancy. And for that, the community health clinics will be essential to improve health of prospective parents, prospective mothers, and also to care for them after the pregnancy. And the question there is we need to be strategic in caring for both the mother and the child together. So these providers who live in the community, and by the way, not MDs, they're usually nurse practitioners, midwives, and other advanced practice providers, have to be able to care for both the mother and the baby. In order to make sure that pregnant mothers come. They always bring the baby for their vaccination and well child examinations, but our data, multiple data, shows that only 4% of them go for their own appointment after delivery. So I think both throughout pregnancy, but before and after pregnancy too would be very important. Thank you.
Dr. Say, thank you so much for those important points. I want to ask, and I almost missed her, she's right in front of me, Representative Vivian Flowers from Arkansas to weigh in as well.
Thank you.
There you go.
Thank you. So first, let me apologize for being late. I was down the hall for a discussion that I needed to be privy to, and I've heard so many stories, not only the stories that you've heard, but literally out in the hall. And I've been writing notes, and I think that the topic of how this plays out in local communities and our hospitals, but I'll add even in our clinics, it really starts, I think, at governmental levels. And so we've heard about how elections impact. And I actually just stood up and talked about how important this is, because a lot of times you think that the things that are happening in your local communities in your state are only happening in your local communities in your state. And I have been overwhelmed. I texted one of my colleagues. I was like, we're really at pandemic levels when we think about how this is impacting lives across every state. So I'll get to it and say that there are things that must be done at every level of government. So when we look at the federal level, Medicaid funding and CMS policy, incredibly important. And while, I think it was important and it will be impactful what the Biden-Harris administration did in terms of expanding postnatal care coverage from 90 days to 12 months. In other areas where we have data and we know that there should be changes made on the regulatory level, those changes are made as a policy change, not as an opportunity for states to say, well, yeah, we want to be a part of it. And, ironically and horrifically, my state of Arkansas is the only state that either did not take advantage of that expansion or is not pending. As a matter of fact, in April, my governor said we don't need it, that women are not taking advantage of the resources that are available right now. And so we will be the only state to not take advantage of that expansion, while we were the first Southern state to expand Medicaid many years ago. And women will still die, even though that expansion took place. So that federal Medicaid funding is important, and really Medicaid funding at the federal and state level, incredibly important. When we talk about stigma, when we talk about access to coverage, if providers and patients know that they are likely to try to get care in places that don't accept Medicaid, or providers know that they are going to be reimbursed at a much lower level, that's automatically going to impact quality of care and equity in care. And then let's think about something that I haven't heard today. The regulatory standards for insurance companies that by and large play the largest role in a patient's relationship with care, whether it comes from the private sector or from the state, that regulation takes place on the state level. It does not take place on the federal level. So what insurance companies are mandated to cover, to do, happens based upon what happens in the state legislatures. And I think that when we consider the changes that can and should be made as it relates to the coverage of women's health, particularly Black women, and particularly what we're seeing happen in terms of maternal mortality, I think that those changes need to happen on the state level as regulation takes place for insurance companies. And I'll just say, those two particular issues and opportunities for change have a direct impact on hospitals. So you have in Arkansas, we have one state system for research. We have 6 academic health units and a hospital. So we have one system for health research and education. And that is where we have seen grants come from the feds. But if the changes don't happen on the state level, they don't impact the care that goes out in areas across our state. And most of our state is rural health, and we're not talking about that. The rural health that is not being delivered has an incredibly detrimental impact. As a matter of fact, in Southeast Arkansas and the lower Delta region, the Arkansas Delta, which is one of the most impoverished areas in the country, suffers greatly. There in South Arkansas, there are very few pediatricians. So when you think about the care that women are going to get post-natal for their children and for themselves happening in that 90 days, all of that ties back to the policies and the politics.
Well, Representative Flowers, thank you so much for sharing that perspective. We have one more panelist I want to weigh in on this question. He may have had the shortest distance to get here because the VCU Medical Center is literally across the street from us here in downtown Richmond. But Dr. David Chelmo is with us, and I'll let David weigh in as well. Thank you.
Thank you. I'm David Chelmo, and I'm a practicing general OBGYN. I'm the chair at VCU and also served for a year and a half as interim dean. And I agree with everything that's been said. When Dr. Sadi was talking about some of the big picture things, I was focused on some of the more nuts and bolts things as we look at policy. We've talked about transportation, and VCU Health has a labor and delivery unit in a rural hospital in South Hill. And I remember having the discussion about transportation with the then CEO, and he basically said, we don't have Uber or taxi, this isn't a straightforward problem that you can just fix with funding or policy. And we haven't really talked about telehealth. How do we do this in ways that people don't have to drive as much? So, supporting some of the reimbursement issues, we've learned a ton about telehealth prenatal care during COVID. One of the big barriers was a simple thing. Patients, we wanted to check their blood pressures at home. We've talked about how heart disease and hypertension and preeclampsia are such giant killers. Well, we had a donation from a grateful patient that allowed us to buy home blood pressure cuffs for the patients. But that should be something that's covered as part of their health coverage. One of the other big issues is staffing these labor and delivery units. We get tons of students who come to medical school from rural communities, very much committed to going back there. But at the end of the day, they don't. And how we foster that, how we create rotations in these areas, not just for students, but I think the big barrier is graduate medical education, the residencies. I've had 2 former residents who were committed enough to do this that they actually did, but we couldn't provide them an elective experience here, because these are small places with busy staff. 2 places did in Montana and Idaho, and that's where they ended up going. So how do we create graduate medical education experiences in places like this? And to some degree, it's a policy question. How do we support this? And then once we get people in the communities, we've got ways of getting there through National Health Service commitments and things, but they don't stay. How do we create a circumstance where people are willing to stay? I had a discussion this morning with an executive from one of the other health systems who was talking about one of their hospitals closing their unit, and it was over salary issues, but there are special things to support people in these communities that are really important to attract high-quality people and then keeping them when they get there. And, we've spent, we talked about the issues with the OB deserts, with units closing down. VCU, South Hill closed their unit back in 2010 or so. When they became part of the health system, we did something that was pretty unusual. We helped them reopen the unit. And we've learned a lot about the challenges of staffing a unit like that since then. And figuring out how we go about creating that as something that people will, it's a wonderful community to live in. That's not the issue. But how do we make the job and support the job so it's something that attracts great people and makes them want to stay?
Dr. Kimmel, thank you so much, and I couldn't agree more with your all your points, but particularly these last couple ones. That's been part of our discussion with the Rural Select Committee that Delegate Cole and I are on, so we'll continue that conversation. We've got a brief period of time, and we'll call it the lightning round, for some questions from the audience. What I'm going to ask our panelists to do, if you are inclined to respond to one of these questions, there's a small yellow button, lower right part of your display board there. Just hit that button. Delegate Cole and I will see you on our little display up here, and we'll have you respond. I'd say let's try to have it, obviously at least one member respond to each question, but if you're so inclined, you really want to respond to that too, we'll take at least 2 answers and try to get through as many as we can. We've got a hard stop, unfortunately. We need to wrap up by 12:30, so we'll do this as quickly as we can, and again, I appreciate all the great questions.
Thank you so much. So we received a few questions from the audience, and we'll start with this one. How can we improve educational pathways to careers that support Black maternal health priorities? And is this about increasing the number of programs, improving access, or changing how we identify and recruit prospective students? Not all at once.
I just would say all of the above.
I want to say improving the cultural diversity modules that they have at stake. I feel like it's not in-depth enough. It is not informative enough. It's just very broad that, hey, if the person is Black, you just have to listen to their request. It doesn't really go into depth of what the culture is like.
Thank you. The next question, and it's kind of in line with this, it says, regarding training for the upcoming workforce, what training strategies have you implemented to ensure upcoming nurses are equipped to help improve the Black maternal health crises?
In Minnesota, we have a new requirement that there's an ongoing curriculum and an ongoing training as far as licensure, and part of it is that they have to participate in an anti-racism training and implicit bias.
All right, we are seeing requests. I don't know where you are, if this was up before the question or after the question. But Representative Cannon, I see your button is up.
Yeah, we're just deeply curious in Georgia about the opportunity to get more Spanish speakers, more medical interpreters who get certified. If there is a doula right now who can speak Spanish, they are not technically certified through the medical interpretation system, so they're actually not allowed to interpret, and that causes concern because that client already trusts that doula, and then that creates a little friction between the provider and the doula. So we're working right now to get more languages included in what's called language justice.
That's amazing. Another question said there's plenty of talk about upping the presence of providers that look like the patient encountering health services during pregnancy. How can legislators help Black doctors get to work in rural areas?
I would say incentives, financial incentives. That's a big issue that I hear a lot of them talk about.
Rep. McDaniels?
Yes, I will echo that, but just take it a little step farther. In South Carolina, I know we provide incentives through funds for our teachers so that they'll go work in rural communities. So advocating that we expand that to healthcare providers so that they will go into the rural communities and that they will also live in those communities to ensure that we have more providers there, particularly, as I stated earlier, in South Carolina, a lot of our rural hospitals have closed. So thank you.
I also see Dr. Tucker.
Yes, to take off on what the representative said about the opportunities. We also, those opportunities and those incentives need to include both providing funds to pay their medical insurance, their that insurance, but also forgiveness of student loans and providing the training and ongoing support that they need, continuing training and development to deal with the culture in the community.
Thank you. Rep. Lands?
Thank you. Again, I'm real new at this, but I know incentives are part of the answer. And I'm also wondering if any other states have looked at maybe having a rotation of doctors who come down once a month or for a few days every month so that people aren't having to relocate but are committed and incentivized to commit to a certain period of time. And I'm just curious if anyone has a program. I hope you'll let me know.
All right, we're going to move to our last question, and I see that there are some who've already requested to speak, so hopefully you can get in on this one. What do you want to see as the goal for mobile care in our rural areas? Doctor?
Did Rick submit this question? No.
I didn't. Well, so on your first, the previous question, one of the things that we've explored, and in fact, I'll use just very briefly an example. I went to Mexico to look at a national kind of a solution with their leadership. And so they decided to build little clinics in all of these rural areas and have the doctors go out. And it was they spent $40 million of World Health money, and it didn't work. So in this case, with Virginia University, they are saying, let's go out and do a rotation exactly like that. We'll contract with our providers, and they will go out. Everybody's happy to do rotations. We can take our incentivize people with their student loans, as Dr. Tucker mentioned. We can bring people out on short term, bring them out at a couple of weeks at a time. People are happy to do that. But to say you move your family to the rural community, that's a problem. They won't generally do that. On the mobile side, I do think the mobiles, we have, again, I've had 28, 30 years of mobile services. We're preparing right now the Gaza solution and working with the government on that. It's an opportunity for everyone in every state to be able to take advantage of technology. When you talk about connecting, telehealth, when you talk about bringing the care up to include surgery, if you talk about the HIFU or these various technologies, they're all changing. And you can take them to the rural health, and Black maternal health could be changed amazingly. That's what Virginia University is doing, is going for that outreach. Thank you.
Perfect. Thank you so much. Unfortunately, we are running out of time, and I know we could be here for 4 more hours if we chose. But we do have a few quick announcements before we close out. Again, thank you so much to all of our panelists for being here this morning and this afternoon, and for each and every one of you for joining us as well. Just a quick reminder, as you are headed to the lunch portion in the Patrick Henry, which is down the street, keep in mind if you do not have a Virginia ID badge that you will have to go through security. So if there are things that you're carrying with you that you may not need to take with you, make sure we travel light. Also, we were just informed that there is a legislator's picture downstairs in front of the General Assembly building. So if you are a legislator, before you go to lunch, please follow us outside for a group picture. And I'll turn it back to you, Mr. Chair.
No, again, I really appreciate everyone who's here. These are incredible insights, and we are so much benefiting from your perspectives from these different states and different institutions that you're leading. Thank you so much, and with that, we're off to the next thing.